I am Dr. Sherry-Ann Brown, and with me I have Dr. David Mazer from the TRiCS-III trial. Dr. Mazer, welcome to FITs on the Go.
Thank you very much. It's great to be here.
We're so glad that you're taking some time out to talk to us, and we have a couple of questions for you. The first question is, tell us a little bit about the trial. What are some of the highlights that you think may change practice in the coming years?
Sure. Well, the TRiCS-III trial was a trial of transfusion strategies in cardiac surgery. There really has been no high-level evidence to establish which transfusion strategy is best for patients undergoing cardiac surgery. As you know, there are risks to receiving allogeneic blood, but there are also risks to anemia. And because of that, clinicians have been adopting restrictive strategies to decrease the exposure to allogeneic blood and decrease the amount of blood that's transfused. However, there is no high-level evidence to establish the safety of restrictive transfusion. So we undertook this trial to provide definitive data to support transfusion practices in cardiac surgery. This was a global trial involving sites around the world, 74 sites in 19 countries, in every continent that does cardiac surgery, except Antarctica, because there is no cardiac surgery there. We randomized over 5,000 patients into a study which had a non-inferiority design. That is, the question was, is restrictive transfusion safe and effective in patients undergoing cardiac surgery? The two transfusion strategies that we studied were a restrictive strategy in which patients were to be transfused if their hemoglobin fell below 7.5 grams per deciliter after the induction of anesthesia for their index surgery until day 28 or hospital discharge. The liberal group had a transfusion threshold of 9.5 grams per deciliter in the operating room and in the ICU, and then 8.5 grams per deciliter on the ward. The primary outcome was a composite of all-cause death, MI, stroke, or renal failure with dialysis occurring again within 28 days of surgery or hospital discharge, whichever came first. The results were very definitive. That is, we clearly established the safety of restrictive transfusion, and not only that, we demonstrated that patients who had the restrictive transfusion strategy were less likely to be exposed to allogeneic blood, and when they got transfusion, the amount of blood that they got was lower than in the liberal group. We did several subgroup analyses and sensitivity analyses, and those were all consistent with the findings in the primary per-protocol analysis of the study. So I think this trial has clearly established the safety of restrictive transfusion in cardiac surgery, and the other thing that it demonstrated again was restrictive transfusion results in lower likelihood of being exposed to allogeneic blood and a reduced amount of transfusion.
Thank you. That was fantastic. And I know that our fellows in training are interested in this because we ourselves might find ourselves as part of the intraoperative arena helping with echoes or anything else. And then, of course, for those doing cardiac anesthesia and also our colleagues in cardiovascular surgery. So thank you very much.
I also say that the findings in TRiCS-III were consistent with other areas in medicine. So restrictive transfusion strategies have been found to be safe or equivalent in the setting of critical care, in the setting of sepsis, and in the setting of GI bleed or orthopedic surgery. However, there is one area that is still outstanding, or still there is some uncertainty about, and that is in the area of patients with acute coronary syndrome. So I'll point out that this trial clearly establishes the safety in cardiac surgery, but there is another trial that is similar to TRiCS-III called the MINT trial that is currently underway, trying to address the same question in the setting of acute coronary syndrome. So I would encourage you to keep your eye on that trial and see what its findings are.
Thank you so much. And as FITS, we look forward to learning more about how we can also be involved in research like this.
Well, I would definitely encourage trainees to be involved in collaborative research. What TRiCS-III has shown me is that it really does take collaborative, multi-center clinical trials to establish the safety of the practices that we're doing and to provide high-level evidence to support our practices or, in fact, change them if they need to be changed.
Thank you, Dr. Mazur. It's been a pleasure having you today.
Thank you very much.
For more videos like this, join us at youtube.com/FITsontheGO.